With that, I think humerus fractures in the elderly, particularly proximal humerus fractures, are interesting. And I think the reason that they're interesting is the outcomes can be somewhat unpredictable. So these are challenging fractures. I think they're challenging in young people, challenging in old people, older people, or what I like to call mature people, primarily because of bone quality. And whenever you have challenging fractures with sometimes unpredictable outcomes, what you see, and here we just go over a little bit of the things that make them challenging, is you see a lot of different ways of fixing things because, as I said, we have a short segment, we have poor bone quality, and because of this, it's really difficult to achieve durable mechanical stability, which is really important because what we've learned with these fractures over time is that they really need motion to have a predictable outcome. And if we can't gain stability, we can't do aggressive early motion without the fear of failure. Lack of motion leads to stiffness and lack of a late functional outcome and eventually poor outcomes. So that's the challenge. And whenever you have a challenge, you certainly start to see a lot of solutions. And over the years, you've seen just about everything: pinning, standard plating, self-made blade plates, pre-made blade plates, nails, hemiarthroplasty, reverse shoulder arthroplasty, and of course, one of the last bigger advances back in the late mid to late 90s was locking plate fixation. And I think every time one of these solutions comes along, we think maybe it's the total package, the very sexy answer. And frequently it's not. And yet so many solutions, yet so many failures because of all the things that we talked about. And so you see a loss of fixation, loss of reduction, failure to achieve motion, non-union, and of course, ongoing discomfort, pain, and dysfunction. So despite all of these efforts, we have to ask ourselves why so many failures. And then, of course, another recent advance to help with these fractures, of course, is the reverse shoulder arthroplasty, but is it the total solution? It does give us some immediate stability. It's not really dependent on bone healing, and we can initiate immediate motion. But every surgery, no matter how magical, can have problems. And so, there isn't one great solution. And if we try to look critically at outcomes when we compare different solutions, so here's an interesting paper from 2020 in the Journal of Shoulder and Elbow Surgery, where they actually looked at hemiarthroplasty, ORIF, and reverse shoulder arthroplasty. The bottom line somewhat is what you would expect, not necessarily a randomized study, but older patients with more medical comorbidities got a reverse shoulder or hemiarthroplasty, and younger patients tended to get fixed. But if they didn't have a reoperation or a failure of the ORIF or hemiarthroplasty, there was really no difference between these groups in terms of motion at a 1 year follow-up. So if you can achieve a similar outcome with a multitude of different options, maybe improving the fixation option can get you what you need without having to give somebody some replacement parts. And I think there's certainly a subset of cases that benefit from being fixed and maintaining the original equipment, so to speak, in terms of obtaining a durable, pain-free outcome. So maybe we should solve some of these problems, and our goals really would be to improve bone strength, sustain stable fixation that'll tolerate immediate motion, and tolerate not only motion, but immediate weight bearing, because many of these more mature patients need their upper extremity even just to ambulate. And so if we can do those things and still fix these fractures, maybe we can come out ahead. So in order to understand why we have fixation failures, we really need to always think about failure analysis and why fixation, even with locking plates, are failing. And once we understand that and what we can control, perhaps we can achieve better outcomes. So one thing we do have control over is implant choice. And the second thing that we have immediate control over is the quality of reduction. And of those two things, probably recognizing the fact that you have to achieve a good reduction no matter how you're going to fix these fractures, is paramount. So back in 2007, one of our residents, Juan Aguadello, uh, looked at our series along with some German colleagues on, what was the efficacy and what did the failure analysis of humeral fractures treated with locking plates? Why did those fail? Because the locking plate on the apple was largely seen to be the messiah, the answer to all of these fractures. And we found one single common denominator that predicted failure, and that was a reduction in varus. And so if we didn't achieve a neck shaft angle essentially of 125 degrees, if it was less than that, it was predictive of failure. So no matter how good the implant is, if you don't reduce the fracture and keep it out of varus, failure is likely. And the reason that happens is that you don't achieve a medial support. So if you don't have medial support in terms of the medial cortex, even if you use a locking plate, it's going to fail. So that's something that we can control. What we don't control, particularly in the mature patient, is bone quality. And here you just see an illustration of the lack of intramedullary cancellous bone in the center lower portion of the head of the humerus over time. And we know that the good bone quality that remains in people of age is really in the subchondral area. So we don't have a lot of resistive support in that area to count on. And so really the only thing we can do to control that is to augment it. So how can we augment for bone loss? Well, we have to fill the void with something. Obviously, there's calcium-derived bone substitutes. And of course, what's been popular in the proximal humerus has been to use a fibular strut to try and fill that void, prevent varus collapse over time. But of course, we know utilizing a fibular strut is difficult. There's obtaining the strut is a problem. It's not live bone. It's difficult to position and it requires a relatively larger entry point. And the fibular strut in these two cases can be placed central to fill that bone void or at an angle, as you see on the left, to try and support the lower part of the head and then capture it with screw fixation. It works, but it's difficult, and it's difficult to execute from a technical standpoint. So what we have, and one of the things that we're going to talk about tonight, is the use of a new nailing technology known as, the IlluminOss intramedullary nailing system. And it's a little bit different because it's a small nail in the beginning that inflates over time. It's a Dacron balloon that we fill with an acrylic monomer that then we cure with blue light into a solid. So the nails that we use in the humerus typically are in the size of 8 millimeters upon entry, roughly, and can expand anywhere between up to 17 and 22 millimeters to fill that void. It's a flexible device, so it can be entered in line or out of line with the femur. So if you want to replicate a retrograde fibular strut, you can. If you want to replicate an intramedullary fibular strut or a typical intramedullary nail, you can. And so it's not limiting in terms of where you put this device in, and it will fill that void up to the limitations of the bone that's actually there. So this is what it looks like. It's a defined shape. You see the circular pattern there that's made out of a wire. It's a radio opaque marking, so we can actually see where the balloon is expanding to, and we know the size that the balloon achieves upon inflation. Important to remember that this device does not interdigitate with cancellous bone. It's all contained within the Dacron balloon, and the Dacron in animal studies has no real bio interaction with the bone itself. The bone doesn't adhere to it, and as I said, the acrylic doesn't leak out of it and interdigitate in the canal. And it just conforms to the shape of the intramedullary canal. Now, there are some technical aspects to consider when reducing fractures and providing fixation with the IlluminOss device. The device will not reduce the fracture. That's something that we have to do. We have to reduce the fracture and maintain that alignment while we insert the device. So we have to maintain that reduction either with temporary fixation or partial application of definitive fixation, and we'll explain that in the case illustration. Um, Once you've done that, you can insert the IlluminOss device, you deploy the acrylic and cure the device. Once it's cured, you complete the fixation construct and you incorporate the IlluminOss device into your fixation because you can drill into it and the device will accept screw fixation to stabilize it. A few IlluminOss caveats to consider is that there's not enough pressure to actually reduce the fracture. So the balloon is a low pressure device that stops expanding when it meets minimal resistance, either from cortical or cancellous bone. But it's not like a airbag of life that'll lift a car off of the ground or anything like that. So putting it in the intramedullary canal, even for a simple fracture, won't create enough rigidity to hold it in reduction like a normal metallic nail filling the diaphyseal isthmus portion of a bone. And again, I mentioned there's no interdigitation of the nail with the cancellous bone whatsoever. So the first case that I want to show you is provisional fixation and retrograde application of an IlluminOss device in a proximal humerus fracture, much like you would use a fibular strut. I don't use this technique. I'll show you my technique in the next case. So this case is courtesy of Bill Harvin down in Houston, and this is his technique. But I think it illustrates the flexibility of the IlluminOss device and demonstrates how it can be used in the one case of retrograde fibular strut application. So in that fracture, what you see here is a reduction using a combination of means, a ball spike pusher, provisional fixation with K-wires to maintain that reduction, and then working around that after planning where the provisional reduction is going to go, he inserts a wire and utilizes a cannulated drill bit to create a path for the IlluminOss device in a retrograde fashion. So in the first slide on the left that I hope you can see my cursor here, um, you see that drill going in there, making the path for the IlluminOss device. And then if you look carefully here in the middle slide, you see the IlluminOss device deployed up into the subchondral bone. You see the wire that delineates its diameter, and that's where the device will expand. And then in the third slide, you see the expansion of the device in the canal here. You see the wire and the actual diameter, and it looks very much like a fibular device that's going to give us some medial calcar support and support in the lower part of the head to resist medial displacement and varus collapse. So once that balloon's cured, you change out the provisional fixation for the definitive fixation. And obviously, there's some challenges with this technique. You really have to know where you want to place the IlluminOss device, and you need to plan your provisional fixation around that so that you can actually get the device in there and maximize its expansion. Of course, you may have some provisional fixation in the way of your plate application that you'll also have to work around. So there can be the challenge of some traffic or hardware congestion that you have to work around. Ultimately, this is the definitive fixation in place. You can see that the screws at the inferior portion of the IlluminOss device have captured that, and the screws in the superior portion have captured a part of that device as well. And so you have a large interconnected area of support to resist varus collapse and ultimately medial displacement. So a lot of surface area there. Okay. So that's what that looks like. Here's the 6-week post-operative X-ray. You can see some abundant callus formation in the area, the lower part of the fracture on both the AP and the lateral X-ray. Looks like it's certainly headed down the healing path. And then, of course, what we were hoping to achieve here in this case is, good stability. Stability eliminates discomfort. Absence of discomfort promotes motion. And so this is the 6-week post-operative follow-up. Certainly not perfect range of motion, but I think very reasonable motion for 6 weeks post-operative. And these are fairly consistent results that we can get, maybe a little better than most in terms of range of motion, but not inconsistent. And I'll try and uh, challenge myself to prove that to you with a couple additional cases. Now, this is a 65-year-old male who suffered a fracture dislocation from a seizure. Here's his dislocation X-rays. And this case will illustrate, provisional definitive fixation in antegrade nail insertion. And this is the technique that I prefer. But a difficult fracture, relatively young patient. This is his CT scan. You can see there's a relatively big Hill-Sachs lesion in the head. The head's not split. I don't have access, or at the time didn't really have access to or the ability to do a reverse shoulder replacement. I haven't been enamored with the results of hemiarthroplasty, so I chose to fix this. And I suspect that there are people in the audience tonight that could challenge this with wanting to replace it. But we went ahead and tried to fix this. And in this particular case, we use provisional fixation with the plate and screws. And so this is an illustration of how to do that. But generally, you want to obtain the reduction um, by manual techniques, however you need to do that, joysticks, traction, clamps, and then typically we'll apply a plate. So here you see my illustration of a plate on the AP X-ray and the lateral X-ray. And then to maintain that reduction, what I do is I use two screws proximally through the plate placed into subchondral bone. And you can see here they're high, but they're placed posteriorly and anteriorly. We're creating a goalpost to target our intramedullary nail with that. And then to maintain the reduction distally, we can either use a clamp, but I prefer to use unicortical locking screws to hold the plate against the bone, clamping it first and then placing two unicortical screws in that position so that we're essentially leaving the intramedullary canal free. And then once you've done that, and you have the reduction that you want, then as one of my former fellows said, it's nail splitting or nail city, just split the goalposts. And so then we insert the nail in an antegrade fashion directly down the canal, medial to the unicortical locking screws and between the two superior screws. So that's where the IlluminOss device would go. We fill it and cure it, and then we can place screws directly into the device. So here's this case that you see here, and the subsequent radiographs where we've placed the nail. This nail, I strive to place it more and more medial through the head, trying to place it through the muscular portion of the rotator cuff to avoid damaging the tendinous portion. And sometimes it's advantageous to use the Navassier portal for arthroscopy and come between the clavicle and the acromion itself to obtain a direct shot. And then we fill the device, the plate with screws, incorporating the device, trying to again to avoid varus and give us that medial support here and subchondral support in the bone. This is what the fixation looks like on a post-operative X-ray. And this is the patient's 12-week X-ray. We do see sometimes, occasionally, we'll see a little bit of collapse of the head here. It's usually not so substantial that you get prominent screws, but we have seen that from time to time, and generally that's just resolved with screw removal or exchange. But this is the patient's function at 12 weeks post-op. I'll turn off the volume there, but that's the kind of motion that we're achieving in that patient um, at 12 weeks. Another interesting case is this is a 72-year-old male, same technique. This is his initial films treated non-operatively, went on to subsequent non-union at 4 months with no bone formation or minimal bone formation. Poor quality bone, heavy smoker. So we decided to augment his bone with an IlluminOss device and fix him with a plate. Here's the post-operative X-rays. You can kind of see the widely displaced screws that were placed initially here to maintain the reduction, the center placement of the nail, and the incorporation of the nail into the device. That's the immediate post-op X-ray. Here we are about 7 months post-op, no pain. a little residual hint of the fracture, but what appears to be mostly consolidation with no evidence of fixation, loosening, or failure. And here's his 7-month um, motion follow-up. So pretty reasonable. Obviously, it's on the left side, but fully functional and pain-free with original parts and equipment. So there's two different ways of doing it, and at least some video documented evidence of motion. What I can tell you is that these patients do achieve stability with minimal motion. We do not restrict the patients in the postoperative period at all in terms of active or passive range of motion or even weight bearing with a walker. And that's worked out pretty well for us. And I do think it speaks to the stability provided because they do gain motion pretty early without too much discomfort.